Okay, let's from June 26th, 2024. First thing that they wanted was a patient that was particularly sick. She had recurrent ovarian cancer and an inoperable small bowel obstruction. So you just needed to read through the lines that things weren't going very well for her. Things probably weren't going to change. And it was a PCS style question. They wanted a family meeting to determine goals of care. As patients near the end of the life, medical complications commonly accumulate, decrease patients' quality of life. And in those situations, it becomes pertinent to weigh the benefits and drawbacks of further interventions. You went with intravenous total parenteral nutrition. Um, they don't even really bother addressing why that's the wrong thing. They're more so just obsessing over the fact that you should just have known that their care was futile. And admittedly, it looks fairly futile here in retrospect, but it's a 56-year-old with ovarian cancer, and not really sure how you're supposed to just decide that it's over for them, but you were. Next question was somebody with infectious mononucleosis. You did not even have any idea that that's what they had because they distract you with hemophilia A, who needs recombinant factor 8. Okay, they had a fever, sore throat, fatigue, and tenderness in the right upper quadrant with a large liver and splenomegaly. So this age group with fever, sore throat, fatigue, and splenomegaly, they really just wanted you to hone in on Epstein-Barr virus causing infectious mononucleosis. And in terms of what's the most appropriate next step, they're looking for AST and ALT tests. Okay, never heard of that before. Totally news to me that you need to check on the liver. But in this case, they have hepatomegaly, they got splenomegaly, and they've got infectious mononucleosis. What thing do they want you to check on? They want you to check on AST-ALT. So they don't want ultrasound of the liver. We went with ultrasound of the liver. They're saying it's not necessary for the evaluation of hepatosplenomegaly in the setting of infectious mononucleosis. Ultrasound provides an increased ability to detect enlargement of the liver or spleen in cases where the physical exam is equivocal. But in this case, hepatosplenomegaly has been readily identified on clinical exam. There you go. Take with that what you will. Next was a 70-year-old man who got brought because he kept falling. I knew at the time that he was falling backward. Falling backward was weird. He had some choking episodes, hallucinations. I'm sorry, he did not have hallucinations. He did have the choking episodes and slurred speech, though. Decreased stride length on gait testing and impaired balance while turning. His speech was soft and he had poor enunciation. You went with Parkinson disease. This is apparently a Parkinsonian disorder. Not Parkinsonian disease. Parkinsonian disorder being progressive supranuclear palsy. It's an atypical Parkinsonian disorder. It's associated with the tau neurofibrillary tangles in the basal ganglia, cortex, and brainstem. Typically presents around 65-year-old with gait instability, oculomotor deficits, and frontal lobe deficits, bradykinesia, and muscle rigidity. I mean, this was really similar to Parkinson's, but there was just like no tremor. And this person apparently has vertical gaze palsy, and apparently it just couldn't be in Parkinson's disease. It just couldn't be. It's got to be supranuclear, progressive supranuclear palsy. Next was a kid with hemophilia A. Okay, so we're gonna just have to just compartmentalize this, dude. I mean, hemophilia A is just essentially von Willebrand's with no extended bleeding time. All right, von Willebrand has a high PTT with a high bleeding time. Hemophilia A has a high PTT, no change in bleeding time, and definitely no change in platelet activity. So all they wanted here was what's going to happen to platelet count, PT, PTT. Well, PT is going to be fine. Platelets are going to be fine. PTT is going to go up just the same way it does in von Willebrand's. Von Willebrand has a high bleeding time. Next, they gave you a multiple sclerosis patient and they said, what's going to help decrease the recurrence of similar episodes? And you gave them steroids. Steroids are what you give to dampen the current episode. But you give subcutaneous glatiramer to lower the odds of recurrence. Other things you could do for that are interferons, monoclonal antibodies, or a broad class of immunomodulators, of which subcutaneous glatiramer is one. So we were all over the fact that it was multiple sclerosis, but we gave them prednisone. Prednisone is only good for the interim, for the right now. It's not good for preventing recurrence of similar symptoms. Next was a 16-year-old girl with hairy lip. She had a high testosterone and a high hair growth, Ferriman-Galloway score. And you picked ovarian tumor, of which they said it fits. It's just not as likely as PCOS. And that's a fair point. I mean, if you're stuck between two, and you at the time you even really couldn't rule out why not PCOS. I guess the reasoning for it was not sure. I mean, I'm not sure why we went with ovarian tumor here. It just seemed like testosterone was high, hair growth. They didn't really give you a ton else. I mean, irregular menses fits both. And the question readily admits that it fits both. It's just PCOS was more likely for high testosterone, irregular menses, and a high Ferriman-Galloway hair score. Next is a dude with gastric cancer. I mean, it's 4-month history of severe constant epigastric pain, feels full after eating only small amounts of food, and he has weight loss. You went with abdominal CT scan. Probably, I think we were at the time we were even thinking maybe more like a pancreatitis, pancreatic cancer type of thing. They really liked the getting full fast, weight loss, early satiety, and epigastric pain. It's really pancreatic cancer except for the early satiety. So, I mean, I don't hate missing this one, but in this particular instance, that's what they want. I guess another thing that kind of, it's just whatever. You can plus or minus on this. One thing that was maybe a little lame is they said the occult blood test, stool occult blood was negative. So just keep that in mind. They're not going to necessarily give that to you if it's gastric cancer. This dude's also not Asian, so I don't know. Just interesting. Next is a 35-year-old dude who came in with really high blood pressure, in my opinion, 155 over 95. And I'm certain that I've read multiple places that blood pressures this high would need 2 drug regimens. And they didn't give you any 2 drug regimens. So we went with measure plasma renin activity because they were perfectly normal BMI, 24 BMI, 22 BMI even, 22 BMI, and a really high blood pressure. So we were just trying to figure out what's going on here. They only like measuring plasma renin activity, apparently, if it's hyperaldosteronism is suspected, which honestly, for this high of a blood pressure, I don't think that that's even necessarily that wild. But in this particular instance, they're just like, well, the dude's got hypertension, so you're going to give him a thiazide. That's lazy. I mean, this is lazy medicine, but that's what they want. They want to just give him one drug for his 155 over 98 blood pressure. I mean, that's just nonsense, but fine. Next is a 32-year-old dude. He most certainly has an immunocompromised state. He's just got he's got shortness of breath, non-productive cough, low-grade fever, and he's banged 10 dudes in the last 6 years. All right. So he comes back with bilateral interstitial infiltrates with a silver stain that's positive. That's kind of a fun PC. Nemesis Girovechi finding silver stain positive and they're like, hey, why is he hypoxic? Why is he at 82%? And you picked a decreased dead space ventilation, which makes no sense. And you knew it made no sense, but none of the other things really like looked juicy either. So what they really wanted was decreased diffusion capacity. Okay, apparently pneumocystis can cause decreased diffusion capacity because of inflammation and infiltration of the tissues, which is creating poor oxygen transfer. Okay, so last one for this section was actually a pretty tough one. This 22-year-old, and she's hypokalemic with high blood pressure. So you figure there's something going on with renin-angiotensin, aldosterone, angiotensin, aldosterone sequence as it happens. Okay. She has a 2-month history of intermediate headache as well. And there's a bruit in the left upper quadrant, which is the big one. So they're telling you that it's renal artery stenosis. And in renal artery stenosis, angiotensin 2 goes up. Apparently, in some sort of bizarre, isolated manner, because the angiotensin converting enzyme doesn't go up, angiotensinogen doesn't go up, brain natriuretic peptide concentration doesn't go up, but for some reason, renal artery stenosis angiotensin 2 goes up by itself. Okay, you can consider an ACE inhibitor, which is hilarious. So it's telling you consider an ACE inhibitor for unilateral renal artery stenosis. Okay, but concurrently, our ACE activity is not up. But we're going to use an ACE inhibitor because the product of converting from 1 to 2 is high. Okay, can we just basically agree that this is nonsense? All right, move on to the next video.